Dr. Mona, it's a truly pleasure to be here today. I feel privileged and honored to be part of this meeting. Over the next 20 minutes, I'll talk about lipid guidelines. I want to start with a couple of cases, define who are the high-risk patients who require to be on treatment, then what are the statin-indicated conditions, and then what are the LDL targets for these patients, how do you reach these targets, and then I want to end with the concept of cholesterol years. So there are many guidelines, and I think for you, I would choose one and stick to it. I will mainly concentrate on the ACC 2018 guidelines and the European ESC guidelines in 2019. So a couple of cases. This is a 53-year-old man who's asymptomatic. He has polycystic kidney disease, and he smokes. He's also hypertensive, well controlled on amlodipine and valsartan. And this is his blood results. His serum creatinine is elevated at 123. His total cholesterol is 4.9. His LDL is 3, so that's the bad cholesterol. His HDL is 1, and triglycerides are 1.9. So my question to you is, does this gentleman require to be on treatment or not? The second is a 20-year-old AGU student who has not shown up today. He's obese, his weight is 107, he's got impaired fasting glucose with elevated hemoglobin A1C. We're questioning whether he's got sleep apnea, and these are his lipids, a total cholesterol of 9, an LDL of 6.1, triglycerides of 3.7, and HDL of 1.25. My question to you, does he need to be treated? So what are the high-risk patients, and what are the statin-indicated conditions? So if I was to look at patients who require to be on statins, you can divide them into two groups. The secondary prevention, so patients with documented cardiovascular disease, and then primary prevention in patients with high-risk features. And the 2018 ACC guidelines, really beautifully divided this into four major groups. The secondary prevention, atherosclerotic cardiovascular disease being group 1, the diabetics being the second group, patients with very high LDL, so if you remember our AGU student with an LDL of above 4.9 or 190. And then, if you don't fall into these three groups, you calculate risk, which I will talk about shortly. So let me just go over these four groups. So the first group is patients for secondary prevention. So you've had angina, you've had a prior MI, you've had angioplasty or bypass surgery. The ESC guidelines in 2019 added imaging. So if you did a CT angio and you saw narrowing in the arteries, even though you did not have an event, you would qualify being in group 1. Patients with peripheral vascular disease, AAA, aortic aneurysms, or cerebrovascular disease if you've had a stroke or a TIA, or on imaging, even though you had not had an event. This is according to the ESC guidelines. Group 2 are diabetics, so anybody over the age of 40. And of course, the more risk factors you have, the older you are, and the longer the duration of the disease, the higher the risk. And of course, this goes for both type 1 and type 2 diabetes. Group 3 are patients with very high LDL. So if your LDLs are above 190 milligrams per deciliter from 4.9, and remember our MSI in AGE was 20 years old, so he would fall into this treatment category if he required to be on treatment. Last group is patients who do not fall into the above 3. So what do? Is you download the ASCVD risk calculator to your iPhone or smartphone, and then you enter the details which you see here, the age, the sex, the blood pressure, the cholesterol, if you're diabetic or not, if you smoke, if you're on any treatment, and then you come up with a number which tells you a 10-year risk of having an MI, or stroke, or actually dying from them. And if your risk is above 7.5%, you're required to be on statins. If you're in the borderline group between 5 to 7.5, then you look at if you have risk factors, other risk factors that are not included here. And if you're less than 5, you're low risk and you do not require statins. So what are the risk enhancers? Well, if you've got a bad family history of heart disease, your mom or dad or brothers had it, if you have a metabolic syndrome, if you have chronic kidney disease or chronic inflammatory disorders, and for the woman, if you have premature menopause or any history of pregnancy-induced preeclampsia, that would put you at higher risk. And some metabolic lipid biomarkers like high sensitivity CRP, which puts you at higher risk, or high Lp(a). So if we come back to our initial diagram here, so for primary prevention, I've put the 4 groups here for the secondary diabetics, very high LDL, and then you calculate the risk. Now, if you look at the ESC guidelines that came out in 2019, they were very similar, except that what they did was they divided patients into low, moderate, high, or very high risk. And at each risk level, you had to have an LDL goal. And if you look that, if you have atherosclerotic cardiovascular disease, which is the group 1 we talked about, you're very high risk, as would be expected. And then if you're a diabetic, most of them would be in the high or very high. You would be moderate risk if you are a newly detected diabetic or you're young, but most of them would be in the high to very high risk group. And if you had familial hyperlipidemia or very high LDLs, you see you're also high or very high risk. So they actually go hand in hand, except that they've looked at it slightly differently in the ESC guidelines. And here they've changed the scoring system, which I don't personally use, versus the ACC guidelines, which are more for North Africa, Europe. They have less details, and I personally, this is a personal preference, I prefer the ASCVD risk calculator rather than this. But the thing that is very clear, which I think is an added benefit to these guidelines, is that they looked at moderate to severe chronic kidney disease. So if you have chronic kidney disease, if you remember our first case, you fall into the high and very high risk groups. And this is something that was slightly missing in the ACC. It was kept as a risk enhancer. So if I was to come back here to the original diagram, I would add CKD, moderate to severe disease, as the 5th group of patients who I would consider to be at high risk. And this would be the statin indicated conditions. So if you just remember this one slide, you'll remember the majority of patients who you should consider putting on statins. So once we've decided that these patients need to be on statins, how low do we go with their LDLs and how do we reach these goals? Well, the American College of Cardiology said if you have documented coronary artery disease, their LDL goal was 1.8 millimoles or 70 milligrams per deciliter. But the ESC guidelines actually went even lower. They actually targeted an even lower LDL because of studies that came out in the interim. And if you're a diabetic with more than 2 or 3 coronary events, your LDL goal should even be less, 1 millimole per liter or 40 milligrams per deciliter. So, the lower is the better. The lower is the better. And how do we get to this LDL goal? How do we get from your baseline LDL level to the target that we wanted? Well, it's through high intensity statins, the addition of ezetimibe if you're not at goal, and PCSK9 inhibitors. And I will discuss these very quickly. So we know that statins block HMG co-reductase in the liver, and they decrease intrahepatic production of cholesterol, leading to upregulation of the LDL receptor. Ezetimibe works at the gut. It blocks this receptor to decrease intestinal cholesterol absorption. And PCSK9 inhibitors block circulating PCSK9. Now, PCSK9 regulates intracellular cholesterol levels. If your intracellular cholesterol level is low, PCSK9 goes up. So how does PCSK9 work? So if you have low intracellular cholesterol, PCSK9 gets released. It combines with the LDL and the LDL receptor to form a complex. Normally, this gets internalized into the hepatocyte, and then it gets broken down by endosomes, and the LDL, of course, gets broken down and metabolized. But the PCSK9 LDL receptor gets disintegrated, and the LDL receptor does not go back to the surface. It gets destroyed. Now, if we block PCSK9, so PCSK9 inhibitors, we block PCSK binding to the LDL protein and the receptor together so that we prevent the PCSK9 binding to this complex. when only the LDL cholesterol and LDL receptor are internalized, it's broken down, the cholesterol is taken up, but the receptor recycles up, and we get upregulation of LDL receptors that takes in more cholesterol from the blood. So PCSK9 inhibitors prevent the breakdown of LDL receptors, which then are put on the surface of the hepatocyte to actually help remove more cholesterol. When we talk about high-intensity statins, remember that it's any statin that will drop cholesterol by more than 50%. So it's atorvastatin 40 to 80, or rosuvastatin 20 to 40. All the other statins are moderate to low intensity. And you need to know how low will your statins work. So a high-intensity statin will drop your LDL cholesterol by 50%. If you add ezetimibe to that, you may add another 15 to 20%. PCSK9 are very powerful. They drop cholesterols up to 60%. And then when you combine all three, you can get an 85% reduction in LDL. And right now we have the statin ezetimibe pill combinations. PCSK9s are given as injections every 2 weeks or every month by subcutaneous injections. So let's go back to our case number 1, the gentleman with the polycystic kidney disease with an LDL of 3. Well, he does not fall into the first three classes. So according to the ACC, you would need to calculate his risk score. It's above 7.5%, so he would need to be on statin therapy. Okay. According to the AC guidelines, he is a high-risk group because of a low EGFR, and his LDL goal will be 1.8. So this case number 1, we're required to be on statins. If you go back to our medical student who has a very high LDL, and hopefully you've ruled out secondary causes, you've checked the thyroid, checked his kidneys, he doesn't have nephropathy, etc. According to the ACC guidelines, he will fall into the very high LDL group of over 4.9, and will need to be on statins. The ACC, their goal is 2.5. ESC, he actually falls into the high-risk group and will also require to be on treatment with an even lower LDL goal. So I want to end with the concept of something called cholesterol years. But before I do that, I just want to quickly talk about hemoglobin A1C. What can it add to risk assessment? Now, this is a very interesting paper that looked at hemoglobin A1C and subclinical atherosclerosis in people without diabetes. So they actually took, we know that prediabetes and hemoglobin A1C are not considered in any cardiovascular risk equation. This study looked at 4,000 asymptomatic middle-aged individuals without diabetes, without known cardiovascular disease, and who are at low risk. And this study looked at the association between hemoglobin A1C and subclinical atherosclerosis. And the atherosclerosis that was looked at was in the carotids, the aorta, the iliofemorals, as well as doing a CT scan looking at the coronaries to detect calcium. Normally, without atherosclerosis, your coronaries should not have calcium. If you have calcium, that means you have atherosclerosis. And then they looked at the hemoglobin A1C, both the normal hemoglobin A1C as well as pre-diabetics, to see if there is an association. And as you see here, there is this bell-shaped curve distribution of hemoglobin A1C. And starting out from a hemoglobin A1C of 4.8%, up to 5.6, it is normal. Anything above 5.6 to 6.4 is pre-diabetes. You find that there is a significant association with subclinical atherosclerosis and hemoglobin A1C in the carotids, the aorta, the iliacs and iliofemorals, and calcium score, which means that the higher your hemoglobin A1C, even within the normal range, there is an association with subclinical atherosclerosis. And if you look at this chart, that says that the higher hemoglobin A1C, you have, of course, high risk of diabetes. We know that, okay? And of course, with all the other risk factors that are associated with a higher hemoglobin A1C, central obesity, metabolic syndrome, insulin resistance, atherogenic dyslipidemia, even when you're euglycemic, so having a hemoglobin A1C of 5.4 to 5.6, you have subclinical atherosclerosis. And the higher it goes, the worse it gets. So that's hemoglobin A1C. So the lower hemoglobin you see, the better it is. And even when you're within the normal range, but in the higher limits, you have higher risk of subclinical atherosclerosis. Now, this is another paper that looked at the impact of lipids on cardiovascular health. And this is really a paradigm shift in the way we look at cholesterol. So how does cholesterol actually cause atherosclerosis? Well, you know that LDL and VLDL remnant particles have ApoB, which is the atherogenic part of the lipid component. And these small molecules freely flux and move from the blood into the wall of the coronary arteries across the coronary endothelium. And once the ApoB goes into the subendothelial space, it binds to proteoglycans and is retained within the wall. And this is called the response to retention. And this by itself provokes a complex inflammatory process that initiates atheromas. And the longer the LDL is there, the lipoproteins gets retained and causes the plaque. And this increases over time until it reaches a critical mass where it becomes stenotic and disrupts and causes symptoms and acute coronary syndromes. And the whole idea is to look at the total atherosclerotic plaque burden. It really has to do with the LDL concentration to duration of exposure. And to understand that, I think we understand when we talk about people who smoke, we talk about their pack years. So if you have somebody who smokes one pack for 1 year, he has a 1 year, one pack year smoking history, versus somebody who has smoked one pack for 20 years. You know, it's the same pack, okay, but short duration, long duration. Now, if you're 20 years old and your LDL is 3 millimoles, and you're 60 years old and your LDL is 3, even though the LDL concentration by itself is the same, the exposure of this LDL over years cannot be the same. Okay, cannot be the same. It's the same concept as cigarette smoking. Okay, the longer the time, the more problematic, the higher the risk is going to be. And this is what brings us to the concept of when we talk about smoking pack years. Now we have cholesterol years. So this looks at the cumulative LDL exposure, which predicts your lifetime risk. Now, all of you know your age. So if you're sitting over here right now, and if you know your LDL cholesterol right now, you can multiply them together. Okay. And I like the milligram years because these are round numbers. So let's say your LDL is 150, okay, and you're 20 years old. So 150 by 20 is 3,000. Anything less than 5,000 milligram years, your risk of having an MI is low. Once you pass 8,000 milligram years, your risk is high. And of course, if you prefer the millimoles, you can do it the same. It's 125 versus 200. And this is one way where if you do not fall into what I showed you, you don't fall into the 4 or 5 categories. You know, you don't have documented heart disease, you're not diabetic, you don't have very high LDLs, you don't have chronic kidney disease. You know, one way to actually estimate risk is this. And I think the importance of this resides in that you may have somebody who right now, okay, has borderline LDL, but if you multiply what will happen in 10 years or 20 years, you can calculate their cholesterol years. And the importance of this happens here. Let's say I have, and this is the threshold of low risk, which is 5,000, which I just talked about. Let's say I have a man with an LDL of 125, and at age 50, I drop his LDL by 40 millimoles, okay? So it becomes 80. Okay, I drop the risk by around 20%, but drop the risk by 20% if the LDL is 80. But what if I drop this man's cholesterol from 125 to 80 at age 30? So I do it 20 years earlier. You see that if you look at this slope, okay, I have this extra additional benefit of lowering LDL when I start earlier in life. And I think this is the paradigm shift. You don't wait until you're 50 or 60 to start being on cholesterol medications. It's the same.
Just careful that the time will.
Oh
I'm
yeah,
afraid
it's
will
the same
close.
concept as smoking. You know, don't say I'm going to stop smoking when I'm 50. I'm going to stop smoking now. Okay, so this is basically the final, okay, which is basically what I wanted to show you is the addition of the cholesterol years to this paradigm, okay, of assessing risk in patients with dyslipidemia. And with that, I would like to thank you very much. Okay, and
Yeah. Did you, he's back.
yeah, maybe I can just show you just the very last. If you can just go back one, please, just back one, because I think this is the take-home message exactly. So I already showed you what the whole paradigm here. I explained that, and then I said primary prevention with low risk. Look at the hemoglobin A1C, look at the cholesterol years, and if you find subclinical atherosclerosis on carotid ultrasound or calcium score, consider statin therapy. Thank you, Dr. Romana. Thank you.